Good morning.
Hello, everybody. Greetings from HCFI Foundation of India Roundtable. I am Dr. K.K. Agarwal. We welcome you all on 45th non-stop HCFI Roundtable. For me, it is 1627th COVID meeting. And I hand it over to Dr. Kalra to select a chair and also to introduce the subject.
Thank you, sir. Good morning, everyone,
Good morning.
and welcome to this 45th meeting of the Roundtable Experts. Vaccines are rigorously tested and monitored and are among the safest medical products in use. Although evidence supports the safety of the vaccines, there are rare instances where the causal relationship between vaccines and other complications, including deaths, has been established or plausible theoretical risk exists. So there
I
are.
cannot hear you, yaar.
Hello, am I audible?
Yes, sir.
Yeah.
Yeah, we can hear you loud and clear. Mahesh ji needs to, I think, do something with his mic or speaker.
These vaccines saves millions of lives, especially in children and adults, against the preventable diseases, vaccine preventable diseases. Like any other drug, definitely some adverse events are associated with vaccinations, which can be common or severe or serious. The various reasons for these complications, or we say this can be due to vaccine product related, including some preservative or adjuvant or stabilizer, or it can be a vaccine quality defect related reactions, or program errors. And next is immunization anxiety related reactions, and last, coincidental events. So common adverse events following immunizations, we know they are very common. They are the local or systemic mild reactions, because vaccine induce immunity. It a response of the body to vaccine is immune reactions. So there may be a mild local tenderness, or even a redness, fever, or some mild systematic symptoms also, which can be because of the virus, various components, or maybe due to adjuvants or stabilizers or preservative used in the vaccines. They last for a day or two and patient is completely all right. But there can be a severe adverse events following vaccinations. Serious event is when it results in a death, require or hospitalization, or results in persistent or significant disability to persist. And severe are only mild, moderate, or severe reactions, but they do not lead to hospitalizations or death or any permanent disabilities. To name a few events which were thought of following vaccinations, important, some we can say, as per CDC report, they were following a flu vaccinations in South Korea. There were 59 deaths recorded in the age group 70 to 80. An autopsy was done in 46 of these patients. All had serious heart disease or some other stroke problem or some other serious diseases. And ultimately no death was associated with serious acute allergic reactions or any other event because of the vaccine. Then dengue vaccines controversy from Philippines. Here children were vaccinated in a school program by a Sanofi vaccine developed by the Sanofi pastures, which resulted in 600 children who received at least single dose of vaccine, they died. So all these kind, and even to pentavalent vaccines also in Sri Lanka, there were some deaths. And like that, even in very important historical event due to polio vaccine, the Qatar incidents, due to the Salk polio vaccine, this vaccine is supposed to be inactivated vaccine, and a particular batch of the vaccine, live polio virus was found, and this vaccine resulted in 40,000 polio cases, resulting in 5 permanent paralysis and 5 deaths, and also cases in contacts also. Like that, sudden infant SIDs, sudden infant death syndrome, they're also associated with some kind of a vaccines at one time. And similarly with COVID-19 in India itself, so far 16 deaths in the age group of 23 to 56 years have been reported, and which are under investigations. Reports are yet to come. So these kind of complications, these were the incidences where death was allegedly thought to be due to vaccine, but it's very difficult to prove the causality relationship, whether it is a vaccine or some coincidental or some other event. So with this introduction, I hand over to Dr. K.K. Agarwal for further continue the proceedings. And Chair Dr. Anita Chakravarti ji, may I request you if you are there?
She's there. She will chair the meeting.
Yeah, I'm there. Can you hear me?
Yeah. Please chair the session.
Anita ji, kindly give your chairman's remarks before I speak.
Good morning, all of you. It's a nice warm day. And we have the good news of having both the vaccines with us in India. And gradually the uptake is increasing. Sometimes up and down goes, but that's okay. And it's essential to know why people are afraid not to take this vaccine. And as Dr. Kalra rightly said, that every vaccine has some or other adverse effects. And one should be aware about it. Not only aware, one should know how to tackle it. Because vaccines are very important. Are important weapon against this particular pandemic. And to the best of our knowledge till now, we have not had too many extremely serious adverse reaction. So I would really request Dr. Agarwal to give his talk on these adverse reaction. And I know he's going to spice it with some interesting antidotes and some interesting parts so that we can memorize and remember it easily. So over to you, Dr.
Thank you,
Agarwal.
Anita ji. Way back, I was a part in my medical college of postmarking a case file. And the case file was patient admitted with diarrhea. Diarrhea stopped, the patient died. So there was an argument. They said, patient came with diarrhea, we treated the diarrhea, diarrhea stopped. Patient died, this is unrelated to diarrhea. Okay. So patient came for a vaccination. So this says no anaphylaxis. So no vaccine related. I think the world is in a denial mode. The whole world is speaking the language of the pharmaceuticals. They are in a denial mode. And if you are in a denial mode, you will not prevent deaths. Today is convert contraindication into an indication. identify vaccine intolerant patients, and then proceed how to give them a vaccine. If you are going to go in a denial mode, and your denial mode is that patient dies, the first statement given is not vaccine related because you did not die in the first 30 minutes. This is what happened when the COVID came. Patient died on 9th day. This is not COVID related because 8th day the virus dies. So therefore, it is not related to the virus because the virus is already dead. I think that is for the statisticians and politicians to make statements, not for the scientific community. For us, a death occurring after the COVID-19 is a post-vaccination death. For us, any death occurring in a post-COVID in less than 3 months is a post-COVID because we know COVID inflammation lasts for 3 months. Therefore, any death occurring in a COVID vaccination for 3 months will be considered as a post-vaccination because the vaccine inflammation will last also for 3 months. That's the topic I'm going to talk about today. And I will give you reason out for everything. And I'm playing a game for how to convert a contraindication into a indication, and how to convert a vaccine intolerant into a vaccine tolerant, and how to prevent even a single death. I can recall my school days. My principal came and said, let's celebrate 99% results. The child came forward and said, sorry, my family says result is 0% because I failed. So we cannot say 19, only one death. 16 deaths is a big number. In India, if you are saying 16 deaths after vaccine, below the age of 60, all dying of heart attack, it cannot be a coincidence. After a vaccine, if 16 people have died, you cannot say not related to vaccine because it is not anaphylaxis. So therefore, that misnomer that vaccine can only cause anaphylaxis need to go. And that's my subject today. So what will happen is, because we are not defining that, this 16 will become 26, that 26 will become 46. And every time we will be in a denial mode means that vaccine, if no anaphylaxis, means it is not vaccine related. Let's have the slides. So I'm basically talking about a vaccine safety. But before that, I want to give two things. 2 patients in Brazil have tested positive for more than one strain of coronavirus. So it's a matter of concern. If this has happened in Brazil, it will happen in other parts of the country. So therefore, coronavirus is not going. The second bad news is India has only 25% seropositivity. So and still we are saying we are towards a herd immunity. We don't know. Some people are saying that 25% has come because other 25% has a waning immunity, whatever may be the reason. But a patient getting positive for more than one corona strain, if the 2 viruses enter into a single cell, we have a problem. And we know that mutations are causing more mortality. This is a statement from UK. And then a bad news comes from India, that we have 13 to 16 deaths. Uttar Pradesh, Karnataka, Andhra Pradesh, Rajasthan, Telangana, Haryana, Odisha, Kerala, Gujarat. Out of 28 lakh vaccinations listed as between the age of 25 and 56, so you cannot say they were frail. All of them heart attack, so you cannot say they were destined naturally only to get heart attack after 24 hours of the vaccine. The very fact they came for vaccination, that means they were asymptomatic, because clearly they said if you are symptomatic, don't take it. And the vaccine taken in each case was Covishield. Then we come back to Norway, 33 deaths, all elderly, 75 plus frail. So there is deaths in Norway is different from the deaths in India, 25 to 56 years. Here it is 75 plus frail. So something happened to people who are 75 plus dying. So we go back to South Korean deaths in October. 23 persons who died after being vaccinated against seasonal influenza. So deaths can occur because of vaccine in adults. So I'm not talking about pediatric children at all. So I only picked up, therefore I'm not picking up even dengue deaths because they occurred in children. I'm not picking up the other deaths. I'm only talking about adult deaths. So the evidence comes from South Korea that people can die of a flu vaccine. 10 people died in Germany, all of them 79 to 93 years of age. And everywhere denial that they did not die in the first hour, therefore not related to vaccination. So Germany and Norway we will discuss as one group. And India we will discuss as second group. Now let us see what is happening in this vaccine. So the vaccine is here, 2 syringes. It is entering into my body. So I'm fearful. By seeing the injection site, I can go into anxiety. I can develop vasovagal. Then the vaccine enters my body. I may get IgE mediated anaphylaxis, or I may get non-IgE mediated delayed reaction, which we will discuss in that. And then I can get thromboinflammation. Let's see how. This antigen that enters my body, this virus, adenovirus, this adenovirus in Covishield is taken up by my cell. This inside the cell, it enters my nucleus. It releases the gene of RNA gene, which I will discuss in coming slides. It comes out of the nucleus. It produces and generates proteins. And that proteins produces is making the antibodies. How? Now imagine I have a antigen presenting cell. In this case, it can be a macrophage or anything. APC represents antigen presenting cell. That means the antigen is inside the cell and antigen is also outside the cell. It is now getting 2 types of receptors, that is major histocompatibility 1 or MHC2. MHC1 will attract CD8 cells and they will produce memory T cells and they will kill the infected cell. So these are called as a standard Th1 response, T helper 1 cell response, which will produce memory T cells and which will produce, they will kill the infected cells. So this is the same response which will happen in an infected virus. The only thing is there are the APCs are pneumocyte 2 cells. Here the antigen presenting cells are in the muscle in the endothelial cells. Then this MHC2 pathway will take up CD4 cells through Th2 pathway. It will attract B cells, which are bone marrow cells, which will produce memory B cells. So there we produce memory T cells. Here we produce memory B cells. Along with that, we produce antibodies. And these antibodies will prevent further infection. So therefore, vaccine is also causing the same Th1 and Th2 response. in susceptible individuals, this can also cause a dysregulated Th1 response and Th2 response. If it is a dysregulated Th1 response, it will cause release of IL-6, it will cause IL-8 and TNF release, which causes local symptoms. If it is a dysregulated Th2 response, it can also produce allergic type of manifestations. Now, what happens with a vaccine? I can be allergic to vaccine or its ingredient. Now remember, whenever you have the first time vaccine in your life, you cannot get IgE mediated allergy. IgE will only cause allergy if it is you are expecting exposed for the second time. And that's the reason when Moderna and Pfizer vaccines were given, they said anaphylaxis cannot come because of mRNA. Therefore, they said, let's look, and they detected PEG. But when they go for the second vaccine, anaphylaxis can come. So we expect more anaphylaxis in second dose of Moderna and Pfizer than the first. In the first one, if you have IgE mediated allergy, it has to be ingredient. Then there is a reactogenicity, reaction to the virus, which can be vasovagal reaction. And then we have reactoimmunogenicity, that is this Th1 and Th response I have just said. So it can be Th1 or Th2 response as a reactoimmunogenicity. Then we talk about immunogenicity, I've just said, reactoimmunogenicity. Then you can have a situation where there are pre-existing antibodies. Now, pre-existing antibodies means that you already have a pre-existing antibodies. As you take a vaccine, the pre-existing antibodies will neutralize and reduce antibody formation to some extent. But if you have a pre-existing non-neutralizing antibodies, that means your titer is so low, then you may develop a disease-enhancing antibodies as seen in dengue virus deaths, that you get exacerbated disease pattern. But government all over the WHO has told all these companies that you kindly, in the animal studies, you make sure we are not seeing DEA response. Therefore, that has been taken care of, because disease enhancing antibodies, all the companies who have given their animal results, they were basically to rule out disease enhancing antibodies. Now we come back to, before I come back to, because the vaccine which is available in our country is Covishield, which is causing symptoms. Let us understand how does Covishield work. This is a messenger RNA of the Covishield. This red portion is the gene of this is the gene of the S protein. This gene of the S protein is what is used in Covishield. Up till now, I was thinking that it is carrying the proteins inside, that this protein is injected into the body. The answer is no. This is basically this gene which is injected into the human body. So this gene is put into the carrier virus. This is the carrier's virus. And inside this gene is injected by converting it into a DNA. This enters the body and this enters into the cell where it is converted into messenger RNA, which comes out. These are not my slides. I have taken it from New York Times, which gives us the whole mechanism. This messenger RNA enters into a ribosome and produces spike proteins. 3 spike proteins, because this is a trimer, convert them into a spike. So inside the cell, now you have multiple spikes and multiple spike proteins. Multiple spikes and multiple spike proteins. They are now antigen presenting cell. Come back to the previous slide. That antigen presenting cells, this now become antigen presenting cells, and they attract either CD4 cells or CD8 cells. So this cell, after it has acquired spike proteins, becomes a antigen presenting cell, and this then makes the antibodies and kills the whole thing. So remember, the new virus enters and they don't allow that virus to be effective with that. That is how this virus comes. So therefore, when I spoke about that antigen presenting cell, this is how the antigen presenting cell is made out of it. Now, this is antibody dependent enhancement, which can occur if you have non-neutralizing antibodies. That's what the things which come. So let me come back to now our main slide. That when you have going for a vaccination, so suppose, let me take an example of anybody who wants to volunteer who has not taken a vaccine. Anybody who has not taken a vaccine? Let me take Dr. Kalra has not taken a vaccine. Dr. Kalra suppose says, I'm afraid of taking a vaccine. So I will first ask, if he comes to me, now I want to take a vaccine and I don't want any complications. So I will ask Dr. Kalra, I will first look for, will he develop a vasovagal reaction, a non-immunogenic vasovagal reaction? So I will ask him a history. Have you ever got a vasovagal in the past? Which we all know, which can be a benign vasovagal or a malignant vasovagal. If he says yes, then I will tell him get vaccinated in lie down position and stay hydrated. Otherwise, vasovagal can make them collapse and they can lose their consciousness in the vaccination center. So the first thing I ask is, have you ever got a vasovagal? He says yes. I will say, then take vaccinated in lie down position and stay hydrated. The second thing I'll ask him is, are you prone to get IgE or non-IgE mediated allergy? So this we need to differentiate between the two. So are you prone to get IgE mediated allergy or non-IgE related allergy? How do we define that? If it is occurring in the first hour, it is immediate IgE mediated. And if it is occurring after 1 hour, but specifically after 6 hours, it is non-IgE mediated allergy. So I will ask him, in your life, have you ever got an allergy to any protein where after the exposure within 1 hour, you develop something? Or you develop something after 6 hours? He says, many times I get after 6 hours, I develop something. So I say, clinically, any history of immediate reaction or any history of delayed reaction. If it occurs within 1 hour, it is IgE mediated reaction. Now see, the whole world is in denial mode because they are only linking it to immediate reactions, that is within 1 hour. And that within 1 hour also, they are only watching people for 30 minutes. Immediate reactions are always IgE mediated reactions. But IgE mediated reactions cannot come with the first dose. In India, we are not getting anaphylaxis compared to Moderna and Pfizer because we are not using PEG. So therefore, till today, we have not seen any anaphylaxis in India, which we will see with the second dose. because unless you are sensitized, you are not going to see. So what we are seeing in India is a delayed reactions occurring after 1 hour, but usually more than 6 hours, and occasionally weeks to months after the start of administration. That's what we are getting. So we are getting after 1 hour. I'll give you an example. Couple of days back, a patient doctor in Delhi developed severe hypertensive encephalopathy, lasted for 8 hours. Day before yesterday, one lady doctor in Banaras developed seizures after 20 hours. So she developed seizures after 20 hours. The message went not related to vaccine. Arey bhai, within 24 hours, you are getting a seizure. This is nothing but a delayed reaction. And that delayed reaction can be either a hypersensitivity reaction or a exaggerated Th1 response. That's what, so both of them called me up to explain what it is. This is what the explanation is. So immediate reaction will come in 1 hour. Delayed reaction will come after 6 hours. So these are the two types of reactions. So if you say, so therefore I ask, will you get IgE mediated reaction? Dr. Kalra says, I am not sure. Tell me what to do. So I would ask him, is your eosinophilic count more than 150 or less than 150? He says, my eosinophilic count is less than 150, absolute eosinophilic count. Then I would say, what is your IgE level? He says, my IgE level is normal. Then if you are a known IgE allergy, then I'll do a scratch test, I'll do an intradermal test, and then I give it. This is what I did with my wife. I checked her eosinophilic count. No, she is asthmatic. She is allergic to egg. She's allergic to many things. So I did her eosinophilic count normal, IgE levels normal. I did a scratch test at National Heart and then gave her the vaccine. So I preloaded, I anticipated that she can develop IgE mediated reaction. So I prevented. She may not have got it. But my job as a clinician is to make sure that 1 out of 1 lakh should not die, because vaccine, post-vaccine death is not acceptable to me if it can be prevented. Then I started looking for non-IgE mediated reaction in her. Because I did not find a scratch test posted, I preloaded her with Montelukast plus H1 plus H2 blocker, which I will come in the next slide with that. So the third thing I look for is Dr. Kalra, will he get exacerbation of his underlying thromboinflammation? So I will ask him, are you pro-inflammatory or pro-coagulative? By checking baseline CRP and D-dimer. If the CRP is more than 1, I know he is pro-inflammatory and pro-coagulative. So he is likely to get an exaggerated Th1 response. So, and he will show a sudden rise in CRP, IL-6 and IL-1 beta. So to prevent acute coronary syndrome in him, to prevent ACS, I will preload him with ACS, that is aspirin, colchicine, and statin. And the fourth question I will ask him is, are you prone to get sympathetic response, over sympathetic response? Will your tachycardia increase if I give you the vaccination, which can be stress, which can be abnormal heart rate variability, which can be your low 6-minute walk distance of less than 700 feet, or he says, 4 kadam chalta hu, mera heart rate 140 ho jata hai. In such a situation, I will preload them with a beta blocker. Now remember, all our life, अगर किसी की डेथ हो जाती है, तो उनके माँ बाप को बिफोर वी ब्रेक द बैड न्यूज, we preload them with a beta blocker and anxiolytic. We preload them with a beta blocker and anxiolytic. All our life, we say ना कि उनकी वो कहती है मेरी माँ को ब्रेकिंग न्यूज देनी है, उनको हार्ट अटैक तो नहीं हो जाएगा, तो we says एल्प्रेक्स दे दो और साथ में बीटा ब्लॉकर दे दो. Similarly, in a vaccine, if you are suspecting a sympathetic response, and here comes the formula of 100. And that formula of 100 is, अगर कभी भी डॉक्टर ने आपको बोला है that please keep your temperature less than 100 and heart rate less than 100, because your body cannot tolerate a heart rate of more than 100 because you have unstable angina. Or if you develop a fever of more than 100, you cannot tolerate. In such cases, we preload them with a beta blocker. Therefore, I have converted now with this every contraindication into an indication. Today in the morning class, the Pakistani people, the Pakistani Medical Association said that their countries has also said we will not give vaccine to 60 plus. Germany says we will not give vaccine to 60 plus. Then whom you are giving the vaccine? Whom are you preventing? You need to prevent these people. Therefore, there comes the role of how to pre-medicate people who are high risk and prevent deaths. The protocol of pre-medication is cetirizine 10 milligram orally 1 hour before the procedure, famotidine 20 milligram 1 hour before the procedure, aspirin 300 milligram the day before and 1 hour before the procedure, Montelukast 10 milligram a day before and 1 hour before the procedure, and consider steroid single dose in the morning if you are dealing with a biologic agent. Remember, mRNA and this vaccine is a biological agent. So they are even talking about considering a immunomodulator dose of steroid, which I have not given so far. With this, I will come back quickly now to. So convert contraindication to an indication to remove vaccine hesitancy. Am I prone to get allergy? I have only given the answer. Penicillin allergy, we do it scratch, we do intradermal test. Why not we do it here? Then we talk about, can I tolerate high fever? Ask yourself, can I tolerate high fever? I just give you a formula of 100. Can I precipitate coronary artery disease? So these 60 people who have died. Now imagine what can precipitate acute MI in them, and that's fever and tachyarrhythmia. So if they have high heart rate, can precipitate underlying coronary artery disease. So all these people, if they would have been given beta blocker, aspirin, statin, they would not have died. Will I get a vasovagal? Ask yourself. Now remember, young people, always ask them a history of cocaine. Always ask them. Cocaine can precipitate MI. So all those young people, if they die suddenly after the vaccine, were they cocaine users? Because cocaine can cause very severe sympathetic response. And over that, if you take an injection of vaccine, 2 sympathetic responses can precipitate sudden death. Smokers. So all those people who were smoking early in the morning, they came back. Smoking will increase sympathetic over response. Smoking will increase your blood pressure by 20. So that's the reason you need to talk about, अगर वो smoking करके आएंगे vaccine लगवाने के लिए, and if they have a pre-existing heart disease, both of them can convert and precipitate. Alcohol. Last night में आपने कितना alcohol पिया था? That can also precipitate a sympathetic over response. Am I frail and comorbid? So frail and comorbid people will not be able to even mild sympathetic overactivity or a mild Th1 response. Therefore, they need to be pre-medicated. They need to be pre-medicated with that. Frail means आप एक कुर्सी में बैठ के 5 बार ऊपर नीचे नहीं उठ सकते, उसे हम frail की definition बोलते हैं. Am I pro-inflammatory or pro-thrombotic? There are multiple things. These are different situations of hypercoagulation. This is a Covaxin cell-mediated immune response. I've taken it from the Covaxin site, which clearly talks about that Covaxin introduces gamma interferon, TNF alpha, IL-2, and also it has an effect on IL-5, IL-10, and IL-13. So therefore, the response to Covaxin is the same cell-mediated response which you get in a normal COVID infection. So this is the last slide again, which I'm keeping it here for discussions. Over to the chair.
Thank you, Dr. Agarwal, for a very good presentation, as usual, lucid presentation. Before I request the other members to ask questions, I had one question. The definition of adverse reaction, because we have our SAE committees. So there are certain definitions for adverse reaction regarding the vaccines in the Rainbow program, Andhradhanush program. So according to that, one has to lodge the reports, FIR and PIR, the first information report, and then it's taken up later on at different levels, from primary health center to district center to the central levels, and you have many specialists sitting and then going through those adverse reactions. So when it comes to COVID-19, there is definitely such a group, and pharmacovigilance also plays a very important role. So what is the role of this pharmacovigilance and the adverse reaction? Is it within 48 hours, 24 hours, 72 hours, or should we wait up till 3 months? I just wanted a little clarity on this.
So I'll come back here is that unfortunately, the policies are made by non-physicians based on their experience in the children. So therefore, we have to be at this moment open. You can't classify AES identified with the pediatric population and interpolate them into an adults. This is for the first time we are having adult population and with a virus which is mysterious. When we know that this virus can continue a post-COVID effect, why don't we expect the same post-COVID effect after the vaccination? Unless you say, I'm only coming back with the same thing. I've created the term called muscle COVID. So I'm debating that why it is not a muscle COVID. The only thing is that in one, you are introducing the virus through the nose, which is interacting through pneumocyte 2 cells, because you blame pneumocyte 2 in this virus. And here you are injecting the same protein into my muscle, and the reaction is the same. If the reaction is the same, the only difference is there the virus protein is replicative, here it is non-replicative. There the protein will last because the virus is replicating more and more new cells are infected. Here the new cells are not getting infected because once you have introduced a titrated dose, it is not going to, but the reaction is going to be the same. How can we have the same formula in a virus which is inflammatory? How many inflammatory viruses we have dealt with in the past? This is an inflammatory virus. So we have to compare it with flu virus program, and flu virus, we have seen deaths all over. We have seen flu virus reactions, we have seen all over. In India, we don't have a flu virus program where we put down AE event for a flu. In adverse event, I don't think so. Because we use flu, we have never been told to report. We have never, because the immunization program is only for the children. Adult immunization program has never been incorporated into adverse event groups. I have never reported. We have seen so many adverse events with flu. I don't think so that we have ever been involved as a physician to report them. Till the PVPI came, till the pharmacovigilance program came. So as on today, I'm only trying to say is all of us are learning. We will learn. This vaccine is going to teach us a lot. So therefore, I am very clear. I am not willing to have even a single death. I'm not a pediatrician. So what happens in pediatrics is not my field. But in adult vaccination, I'm not willing to accept even a single death. Whether you say not vaccine related or vaccine related, 16 deaths within 24 to 4 or 5 days occurring, all because of MI, cannot be coincidence. They all are preventable.
Sir.
Thank you. Dr. Kalra, please.
Yeah, I think as per operational guidelines about AEFI, operational guidelines issued in 2015 and modified in 2016. What I feel going through this, first of all, in the definition as you asked, AFI, they have not mentioned the time period. Secondly, probably is not only applicable for pediatric immunization, this also probably also concerned with adult vaccinations also.
No, have they defined AEFI for COVID? We are here only for COVID. We are not here
No,
for.
it's general.
So
I'm talking about.
if they have not identified it for COVID, then it becomes our duty as a roundtable
Yes,
to
yes.
come back with what can be the. I mean, that's the duty of our roundtable.
Yeah,
Because if they have not defined AEFI, we should say that every death within 3 months of vaccination should be investigated. That's
right.
all.
So they are general definition. They are defining
In a
the
general definition, say suppose you, this is what the statement I say. Patient came with diarrhea stopped patient, right?
yeah.
You say I gave a vaccination. Patient 1 hour he did not develop anaphylaxis. Patient died. This is not vaccine related. How can it not be a vaccine related?
Exactly.
We are not talking about don't give vaccine. We
Yeah.
are, see, if we tell them that you can convert a contraindication into an indication, your hesitancy will go away.
Let
That's
me.
what I'm trying to say.
Yeah, let me read the definition given in this guidelines. AEFI, and AEFI is any untoward medical occurrence which follows immunization and which does not necessarily have a causal relationship with the uses of vaccine. The adverse event may be any unfavorable or unintended sign, abnormal laboratory findings, symptoms, or disease.
तो ये पेशेंट जो मरे हैं फिर कैसे आपने बोल दिया वैक्सीन रिलेटेड नहीं है? 16 लोग मर गए, 33 लोग नॉर्वे में मर गए, 10 लोग जर्मनी में मर गए, and we say non vaccine related. That's the first statement comes. You say not anaphylaxis related.
So
then I can understand. If you
I
say
think,
non anaphylaxis related, I can understand. But you cannot say that how will we prevent more deaths? I am very clear. I will not allow any of my patient to die. I am following my protocol. Today, this protocol was discussed in the CIMAO meeting, where 12 countries were present, and everybody agreed on principle. And they said convert it into a statement and release it, send it to WHO and send it to all the governments. And all my CIMAO doctors, all of them have followed this protocol, whosoever were present. They said, otherwise they said we were not going to take. Everybody was saying that we were not going to take this vaccine, but because you brought it into a protocol, we all followed the protocol and now we are fine. Otherwise ये लोग ले ही नहीं रहे थे.
Okay, thank you. Thank you, Dr. Agarwal. Actually, Dr. Kalra, in the case definition, they haven't even given the time.
yes, time is missing. Yeah.
Second thing is, yeah, you were correct on that. That HPV has an adverse reaction group. In fact, that is why HPV vaccine in the adults had a lot of things occurred in Tamil Nadu during the first round of HPV. But that's all solved now. That doesn't come into the picture. Yeah. And as Dr. Agarwal said, yes, if we can, it's a new virus. Everything is new. So maybe we have to be prepared and. We have to remember that this could lead to any of these episodes because its pathogenesis is multifocal and at various levels. So that's one thing, but it should not come into fear psychosis of the persons who are taking the vaccine. Then that's going to be a
statement by Dr. N.K. Roda yesterday is the same. We are very slow and cautious in the first phase because we are learning about this vaccine. Therefore,
Absolutely.
we are slow. He says once we build confidence, we'll increase the number of vaccinations per day. That's a statement which came today in the newspapers.
And
Yes.
no, this was made before also, and that's how we need to carefully look at AEFI module, which is specifically prepared for COVID-19. That's where, and we can dissect piece by piece, and we can incorporate whatever you've just said now, and that can be resubmitted to the government.
Absolutely.
So I feel that we need to look at, because that has been prepared, especially keeping in mind COVID-19, and Dr. N.K. Arora has been repeatedly telling that, you see, this is the vaccine which has to be treated differently in terms of that we cannot give it anywhere and everywhere, though we are thinking of going it in election mode and all that, but what all facilities will be there in the schools and all that. So that is another thing which we need to look at, whether they should be only given in the hospitals where we can, have emergency trays, and action is fast. We act in golden hours, so that's what is important also.
And that's the reason I'm saying that the high risk patients must be given vaccination, not in a routine. High risk patient has to be treated by their treating doctors in a way that they convert a vaccine intolerance into a vaccine tolerance. So I am of the firm opinion, everybody can be given a vaccine, provided we pre-medicate them with evaluation and pre-medication. So vaccinating high-risk people is an art, not a routine. That's what I'm only trying to say.
Oh, I had a question here.
Can
What
I
the
come in?
question which I had, I had was, what about the long-term effects of the vaccine?
We
The
don't know.
immediate effects can be taken care of, but suppose a long-term effect occurs after 2 months,
I
will you be able
expect,
to monitor each of
I
them?
expect post-vaccine COVID also, I expect may happen post-COVID, like a long COVID, because the protein is the same. Protein is the same. You are introducing the same protein. Why you will not have reactions? So therefore, we need to anticipate them and prevent them. I am of the firm opinion. I created this formula ACS for ACS. If you want to prevent ACS, now this is applicable for anything. That if you are anticipating a death due to acute heart attack, to prevent ACS, give ACS. Give a tablet of aspirin. In any way, we give Disprin. Give colchicine and give a statin dose. You may be able to prevent a major catastrophe. I'm putting it only because I discussed the same discussion held with the CIMAO. It is happening here. I will discuss the same thing with the general practitioners group tomorrow. And then I'll come back to a final statement. I am of the firm opinion, only one statement I'm making, that every contraindication can be converted into a contraindication. As we are saving lives in COVID, similarly, we need to save post-COVID vaccination complications, and they are manageable and preventable. So I rest my case for arguments.
I have a question.
So can I come in?
Yes.
Can I
Yeah,
come in,
please,
Chair?
Dr. Mishra.
Thank you very much, because I have to go for another meeting today at 12, unfortunately. So I just wanted to give my quick reaction. So going with what Dr. Agarwal is mentioning in terms of his firm, convincing approach, which he has also been able to convince the doctors from other countries, I would suggest that, what I have seen, that certain voluntary initiatives taken and well documented can get converted into mandatory requirements. So I would only suggest that please document it, make it your voluntary initiative out of this group, and then let that get converted by the policymakers and the lawmakers in terms of making it mandatory, in terms of what are those protocols which needs to be adhered to be able to convert all the intolerant into tolerant. So that's what I would like to say, and I would like to excuse myself, Chair. This is what my views are, that we should take this advice of Dr. Agarwal seriously in terms of moving forward, and how we can move forward out of this group is what I'm looking for from experts in the group. Thank you very much.
Thank you, Professor Mishra, for your
May
valuable inputs. Yeah, please do.
This is just as a follow-up of the discussion which we had a couple of weeks back of advice on the CRP and the IgG. So I went and registered my name for the vaccine, but my physician at Bombay Hospital suggested me to evaluate these readings, and I got my IgG done, which is about 110, and CRP was about 7. So I was suggested, because I'm running 70 and of course with controlled diabetes and hypertension, to wait till the reaction and all these reports, what we are reading, gets a little more clarified. And although I'm willing, but I was told to hold on the vaccination for some more time. Although I'm a little scared of performing surgery because of this, which of course we are taking all precaution. But of course, I'm open to suggestion from Dr. Agarwal.
So for Ashokji, in your case, once I have seen your IgE levels are normal, but your CRP is high. So I will bring your LDL to around 50 by statin, start colchicine and a statin together. Within a week, your CRP will come back to around 2 or 3. And then under cover of that, I'll go ahead with the vaccine. That's I'm doing with everybody and with 100% success.
Thank you, Dr. K. Thank you.
Come in, Dr. Neta.
Yes, Balbirji.
Thank you, Dr. Agarwal, for the very, very well researched and documented presentation. But as Bejon Misra highlighted, that how do we communicate these findings and safety protocols and across the country?
So Balbirji, as a routine, we make all our presentations live on YouTube and Facebook. So we are on a public domain every time. And the minutes of this every week, we send it to 2.5 lakh doctors, including all ministries. They have been going from day one.
All ministries. Do you send it to the health ministry?
Yes, all of them are on our email list, and it goes as a roundtable minutes to everybody. Every doctor receives them, the ministry receives them, and internationally, all the countries in the world, they receive our minutes. So it goes as a routine to everybody.
So because
but the only thing is we have not been sending it as a letter to the health minister to kindly consider it. Our minutes have been going to them, but we have not been sending it like one-to-one. So we will do that from today.
May I come in, sir?
No, 1 minute.
Yes, Upasana, please.
Sir, as today when I was listening to you, and I am working in healthcare facility, but I must appreciate the way you explained everything. Can't we make a guideline for all the vaccination centers? So before vaccination, they should check all the parameters of a person who is going for vaccination, because then we can save more lives. I don't think everyone is that much aware as you have done this research of, this IG level and other things. So, sir, can you take this initiative that send it to IMA and they have to distribute to all the doctors? Because I know everybody is not aware that if IG level is high or CRP is high, so they should not go for vaccination. Thank you, sir. Please.
Just want to add one thing, because all these safety protocols are not being implemented on the ground, despite all the effort at communicating. Because I know an instance of a doctor in Bombay who was given an appointment in Nair Hospital, and when she went and told them that she has asthma, they refused to give her the vaccination at all, nor did they tell her of any safety protocol to be followed.
So probably the awareness has to be there, and that's precisely, I think, what Dr. Agarwal is saying. By these programs, the awareness is going, but it may have to go to the right persons who make the policies.
On the field level, and also it should be, I think it is very urgent, because people are being denied vaccinations right now to people who have asthma, for example. Thank you.
Yeah. And anyone like to comment on this, please?
KK, can I intervene? KK.
Yes, Dr. Raya, your turn.
Good morning, everybody. Dr. KK, I congratulate you the way you have explained all these things, because as a general physician, I'm a family physician, we are facing a lot of queries from the families and from the kids also. And this is other members from Roundtable have also suggested, and I also request you, as far as this Roundtable protocol or Roundtable observation, you should circulate to the authorities also. And for our benefit, I request you to kindly make it, these are the investigations which we should do, these are the precautions, these are the medication we should do. As you are saying, the contraindication can be made into indication. That's a very good idea, because a lot of people are having still apprehension and they are not getting vaccinated because of all these things. Even as a general physician, again, I'm telling you, I request you to kindly make this a brief note, which will work as a ready reckoner for the physician, general physician, for every doctor, which will help us. And the recommendation should go to the ministry, ICMR, and to the other persons, other authorities, as whatever you have studied, whatever you have penned down about this vaccination adverse effect and the indication and contraindication. This is my humble request to you. Thank you.
Thank you, Dr. Balbi. Anyone else wants to know something or ask some queries, has some queries?
So, Anitaji, before you give a final remark, let Dr. Mahesh Verma sum up, and then you give your chairman's remark. And
good
then
morning,
Dr.
sir.
Kalra can
Good morning, sir.
Yes, Dr. Mittal.
I just want to share that my wife is a very high risk. She is a dentist by profession. She is a breast cancer survivor. She was a hypothyroid, obese. Under your guidance and your all pre-medication. She got vaccinated 3 days before, and she is absolutely fine now. There is no problem, sir. This is
Good.
experience I want to share.
So Anita ji, they were not ready to listen to the husband, so they all came back to my show. That each one of them asked questions to me, and they said, if you assure us, then only we'll go for the vaccination.
I think we should direct everybody to KK only.
And that's what I'm doing. That's what I'm doing.
Dr. KK.
I'm only handling how to get vaccinated in the contraindication.
I appreciate your efforts, literally. And that's why I'm requesting you.
That's excellent. And written guidelines have to be circulated more. That's what I feel.
I'll do that.
That's very important.
I do agree. Whatever you have given today's knowledge, I might have missed a lot of things while listening or while penning down. So I'm requesting we want in a written, which will work as a ready reckoner.
So this is Mahesh Verma and then
Yeah. Okay. Thank you so much for giving me this opportunity. So Dr. Kalda opened today very important topic, and as Dr. Rai said that he has missed a lot of information. So I will give him the gist of what we discussed today. So it will be useful, and it's also nice always to rewind and so that we can remember all these things. So Dr. Kalda started and he said that adverse reactions like local immune reactions are very common with mild symptoms, and it is due to preservatives or due to adjuvants. But the severe reactions, when it causes death or persistent disability, and which is of course rare. And he said he gave an example of post-flu vaccine in Korea where almost 59 deaths happened, and there were heart diseases, there was stroke, etc. Except these, there has been no such report where vaccine has brought in some severe reactions. He also said that dengue vaccine was given by Sanofi, which had some casualties in children. Even in Sri Lanka, something similar happened. He also gave an example of Salk polio vaccine, which had a serious issues. And then he said that the post-COVID-19 vaccine in India, there has been 16 deaths, and which are being investigated. Is it because of the vaccine or other things? But very difficult to prove whether it is vaccine or other causes. Dr. Anita Chakravarti, as a chair, said that the 2 vaccines are available in India, but people are very afraid, and one must know how to tackle any adverse reaction, which has not been too many here. Dr. K.K. Agarwal cited a post-mortem case, which he remembered that where patient was admitted with a diarrhea, and then the patient diarrhea stopped and patient died. The patient had come for vaccination as it had no anaphylaxis. So not vaccine related. Today, all world in denial mode, and we are only speaking of pharma company languages. And he said the patient died. If the patient died on the 9th day, it is not related to virus, as the virus gets killed on the 9th day. So it has to be related to vaccine. Any death which is occurring less than 3 months post-vaccination is to be considered to be a vaccine related. And how to prevent a single death, that is our motto. And even if one death is happening, it is our failure. He says 16 deaths is a big number and cannot be COVID vaccine. It cannot be not COVID vaccine related. So we cannot be in a denial mode, as it will keep on increasing. He said vaccine safety is very important. The 2 patients have tested more than 2 strains of corona in Brazil. And he said this is a serious matter. This can have a problem in our country. We have only 25% of seropositivity and another 25% where the immunity is waning. So it's a big alarm for us. And he said if 2 viruses in a single cell, we shall have problem. He said out of 28 lakh vaccinations done so far, which are pertaining to age between 25 and 56 years, we have had 13 to 16 deaths, and they were all healthy. They were all asymptomatic. They had no cardiac issues. So it's a big matter. We need to take it seriously. In Norway, 33 deaths have happened. Of course, they were all 75 plus. In South Korea, 23 deaths have happened in October 20, which was due to seasonal influenza, and out of 13 million. So again, because this vaccine is more like a flu vaccine, So we must keep that in mind. He also said that in Germany, 10 deaths have happened between 79 to 91 years of age. There are two kinds of groups. He said if we have to compare these kind of pattern of deaths which is happening in different parts of the world. He said the vaccine is entering the body. Patient is getting fearful. There is an anxiety. So there can be a vasovagal shock, and there can be IgE modulated anaphylaxis, or there could be a non-IgE related reaction. Inside the cell, the virus enters, it enters nucleus, enters RNA gene, produces proteins and produces antibodies. If we have antigen producing cell, that is APC, can produce memory T cells and kill the infected cells. Same response will happen here with vaccine. Similar pathways here. There will be memory B cells which are produced and Th2 cells. So this can cause dysregulated Th1 and Th2 response, and it will cause to local and allergic response. That was a pathway. He explained that how this can happen. With vaccine, one can be allergic. First time, one does not get IgE-based allergy. Only happens second time. And he gave a very good example of US and other where the Moderna and Pfizer vaccines are happening, has been given. So expecting more IgE allergic reaction here during the second phase. He said the reactogenicity can also cause vasovagal reaction, reactoimmunogenicity, which can bring about Th1 and Th2 response. He said pre-existing antibodies, when there is, it will reduce neutralized antibody, and if pre-existing non-neutralizing antibodies are present, can cause disease-enhancing antibodies. So Covishield vaccine, which is the one which is causing reactions here in India, it has a gene of S proteins, and it is put in the body and converted into a DNA. And if mRNA enters the ribosome of a cell, it can convert into multiple spike proteins. These are now antigenic presenting cells, and this makes the antibodies and kill the virus. This happens when you have non-neutralizing antibodies. So when one goes for a vaccine, and he gave an example, if he is afraid and does not want any complication, we must determine first whether he has had any vasovagal reaction in the past through history. If yes, take it lying down and remain hydrated. Second thing he said, are you prone to get IgE or non-IgE mediated allergy? How do we define it? He said if within first hour, it is most likely going to be IgE reaction. And if beyond, it is non-IgE based reactivity. So again, through history, we can make out if he has had any reaction beyond 6 hours, delayed reaction. So why the whole world is in a denial mode? He asked, because we are looking for immediate reactions, which is only IgE based reaction, and we are likely to see it in second dose. So he said when same people will get it second, it is more likely to be, there can be more reaction, because that is going to be non-IgE based reactivity. There has been delayed cases of seizures or cardiac encephalopathy. It could be due to vaccine, non-IgE mediated reactions. Determine, another thing he said, determine eosinophilic count. If less than 150 and if IgE level is normal, do a scratch test and then take the vaccine. Post-vaccine, look for non-IgE based reaction. Third thing, whether he said whether patient is pro-inflammatory or pro-coagulative, whether CRP is more than 1, then better preload with ACS, aspirin, colchicine, and statin. And if 6-minute walk test is positive, preload the patient with beta blocker or an anxiolytic. Formula 100, he said, keep your temperature less than 100 and HR less than 100. And if can go beyond, preload such patients with beta blockers. He said, pre-medicate, this is the very important thing. He said, pre-medicate all the high risk with cetirizine, formatidine, aspirin, montelukast, steroid, especially single dose if you are dealing with any biologic agent in the vaccine. Penicillin allergy should be undertaken, reducing exacerbation factors, example, coronary artery disease, all those things which are reducing exacerbation of CAD. And whether the patient is a vasovagal prone or there's a history of cocaine, because he said cocaine can cause very severe sympathetic response. Also smokers, there is an increased sympathetic response, and also they have an increased blood pressure. Also alcohol, especially the previous rise, how much alcohol has been consumed, that can also cause high sympathetic response. And he said if patient is frail and comorbid patient, they cannot tolerate increased sympathetic response. So we have to be careful. Dr. Anita Chakravarti, adverse reactions and role of pharmacovigilance is very important. Dr. K.K. Agarwal, cannot be compared with viruses as in children we have done in the past in vaccination. Here, viruses are replicating, and we have to compare it with flu virus, as it is first time we are undertaking it in the adult population, and we are making a new learning. Dr. K.K. Karada, AEFI guidelines have not specified any time period. Dr. K.K. Agarwal, it has not been defined for COVID. So we need to investigate every death happening within 3 months. Convert contraindication into indication so that hesitancy goes away. Dr. Neeta Chakravarti, AEFI has not given any time, but for HPV vaccine, it has mention of adverse reaction, but she agrees it being a new virus, and we need to learn. Dr. K.K. Agarwal, we are slow in first phase, so because we are learning from it, as it has been quoted by Dr. N.K. Arora. Dr. Sunil Agar, we need to give it in hospital settings only and not in the schools, because to management for the golden period management. Dr. K.K. Agarwal, everybody can be given provided we evaluate high risk and manage. Post-vaccine COVID may also happen. He warned all of us. And he also said the final statement made by him is every contraindication can be converted into indication. Dr. Bedon Mishra, convincing approach by Dr. K.K. Agarwal, but certain voluntary initiatives must be taken and documented and can be used for policy making. Dr. Ashok, he has been asked to hold on because his CRP was high. Dr. K.K. Agarwal, bring CRP to 2 or 3 and improve your LDL before vaccination. Dr. Balbir, whether these discussions are well communicated. Dr. K.K. Agarwal, minutes are being circulated to everybody except Ministry of Health. Dr. Upasana Arora, whether all parameters are assessed of each patient prior to vaccination. Dr. Balbir, these safety protocols are not in place in centers and they are not even aware of it. Dr. Chakravarti, this information should go to right people who make it policy. And Dr. Balbir said it must be done urgently, immediately. Dr. Rai, roundtable observation to be circulated to authority as well as abstract of it, what happened today must be shared between doctors group and IMA. Thank you.
Yeah. Thank you, Dr. Verma, for as usual summing up in a beautiful way. I thanks Dr. K.K. Agarwal for his wonderful, very useful presentation to convert contraindication into indications for COVID-19 vaccine. I think everyone...
Dr. Kalra, Dr. Anita's chairman remark are still pending.
Okay, thank you so much. Wonderful presentation as usual, need of the hour. And I thought that the theme should have been converting contraindications to indications for lowering the post-vaccine casualties, as well as for extremely good coverage so that we can combat if and when the second spike or if some variant of the virus comes. So it has been dealt beautifully, and we had a very excellent interactive session. With these words, I hand it over to Dr. Kalra.
Thank you. I will continue here. Sorry. So I think everyone should above the age of 18 must get vaccine with the following safety protocols, which has been explained beautifully by Dr. Agarwal. I think there's a need for creating awareness among not only the public, but among the professionals, colleagues also, so that there's no one, they are able to guide their patients, as well as everyone gets the vaccine without any fear. I will just end here, and thanks all the members for attending this session today and interacting with the discussions, and see you again next week, next Saturday, same time for another interesting topic.
Thank you, everybody. We'll be
Thank
back
you.
next week at same time. Thank you.
Okay.